want to welcome everyone here this morning, late morning. I'm Colin Murray. I'm the Executive Director with Dane by Local. So we have, I think there's 11 people joining us on Zoom today, besides those in person. So welcome everyone. Glad you were able to join us. So Dane County Credit Union is hosting the event today. And Mark, would you like to say a few words on behalf of the credit union?
Thanks everybody for coming here and online. It's really nice to have everybody here. We're very local, as you know. So I just wanted to also say, like, along with Dane Local, we also like to make sure that all our team members and employees do local events, volunteering. It's extremely important to us. And I'm also here if there's any questions. Financial education is also a big portion. So if any of your employers or you have any questions whatsoever on education with finances, that's what we're here for. Thank you.
Great, thank you. Thank you for hosting, we appreciate that. And our speaker today is Dr. Nicole Hemkes with Advocates MD. She has an interesting approach to dealing with healthcare. So with that, I'll let Dr. Nicole take over. Thank you.
Hi, as Colin said, I'm Dr. Nicole Hemkes, and I did a presentation, I think, prior to COVID a couple of years back, and talked about how to make healthcare more affordable for businesses, and talked about direct primary care. This is going to be a somewhat different presentation, some similar material, but I'm trying to use more examples and kind of provide more real life situations and things for people to make this a little bit better. But please, if anybody has questions, I don't know if there's like a chat that they can ask those questions through, or
there is.
Okay. Great. Yeah, so feel free to type those into the chat, or people that are here, we can answer questions at the end. So a little bit of my background. I am a family medicine trained physician. Actually grew up in Florida, did my training in North Carolina, lived in Chicago for a time, and then moved up to Wisconsin. But for most of the last 13, 14 years, I worked within a traditional fee-for-service system, which means a big hospital, a healthcare system owns the clinics that primary care doctors work in. And we bill based on the visits when we see a patient, if we do a procedure, if they do blood work, if all of these things are billed separately to the patient's insurance. So this is the fee-for-service system that we're used to. And what we're finding is that over the last 10 or 20 years, it was especially accelerated after the Affordable Care Act 10 years ago, that health insurance has become increasingly expensive. So we know that an employer, typically healthcare insurance could be their second largest expense after payroll. So we're looking at more innovative ways to provide healthcare, quality healthcare to employees, people in general, but I think businesses, since most people get their healthcare benefits through their employer, this is especially pertinent to businesses. So, we talked about, I mentioned kind of the financial part of this, but I think in general, despite the fact that, the United States has the most expensive healthcare system in the world, many of us have probably maybe not had the greatest experience with the healthcare system. Either we go to make a doctor's appointment, you have to wait a long time to get in to see the doctor. You get in there, they spend, 5 minutes in the room with you. So we kind of talk about how the system is kind of broken. It's really complex and complicated to do simple things. If you need an order for an x-ray, it seems to involve 4 or 5 different people to do something that, why does it have to be that complicated? As a physician, we see and hear about a lot of doctors burning out, in the system where they're seeing 25 patients in a day and going home with 2 to 3 hours of paperwork every night. So what we're seeing, locally and across the country is that doctors are working part-time. They are retiring earlier than they used to, just to kind of cope with the way that the system is right now. And again, we talked about the cost. So first thing I was going to talk about is a model of healthcare that I actually work in now, which is called direct primary care. So basically, it's kind of taking the idea of health insurance, and we've always thought of health insurance, or we traditionally, I should say, thought of health insurance as we need health insurance in case something bad happens to us, right? If we need to go to the hospital, if we need to go to the ER, we need surgery done, we need health insurance for those things because we can't afford those things. What health insurance has morphed into, though, is basically we use it for everything. We use it when we go in to get our blood pressure checked. if we need a prescription refilled, if we sprain our ankle, we go into the doctor, we give our health insurance card. What if we changed our mindset about that and we still had health insurance and we used that for the catastrophic things, the big surgery, if you need to go into the ER for something, things that will be very expensive, hospital related things. But if the everyday stuff, when we go into the doctor for a checkup, go in there for a blood pressure check or get blood work done, what if those things we did not use our health insurance for? Because that would actually, in reality, make it a lot less expensive for those things. So that's what the direct primary care model has done. It's a membership-based model where on average, an adult might pay $80 a month for a membership. A child might be $30 a month. And so when you go into the doctor for a visit, there's no charge for that visit. There's no copays. There's no deductibles that you have to meet. Your care starts immediately. There's no pre-existing condition clauses. So it's very different than the fee-for-service system. So as the slide mentions, all office visits, procedures, we do telemedicine, we do home visits. We actually do charge a small fee for home visits. If we do a test in the office that is not something we have to send out to somebody else, we don't charge for that. So this is just kind of a list, I think this is on my website, but of things that we can do in the office. A family medicine doctor is trained to do a lot of things. We don't do most of the things we're trained to do out in practice. I used to deliver babies. I was trained to do general surgery. I was trained to do, I don't even remember all the stuff, but so a lot of the stuff we give up as we get out in practice. But part of the idea of this is that some of the things that are within our scope of practice and that we are comfortable doing, we can actually do. What happens again in the system traditionally now is that if I'm a family medicine doctor that works for a big system, and if I have 25 patients that I'm seeing in a day, if that person walks in and they say, well, can you just take a look at this mole? Or, I have this, I sprained my ankle. Can you, take a look at that? I might refer that patient to a dermatologist for the mole. They broke their ankle. They'll send them to an orthopedist to take a look at that. A lot of it has to do with not having the time. It's not necessarily that the doctor doesn't have the knowledge or the ability to take care of those things, but if they have a 10 or 15-minute visit, it's almost impossible to be able to have that kind of scope to take care of all of those things. So this gives you an idea of a family medicine practice, what we are able to do in a lot of direct primary care practices that are across this country. So the direct primary care movement started about 15 or 20 years ago with a handful of doctors, and now it's about 700 practices around the country. Our practice, when we started 2.5 years ago, was the only pure DPC practice in our area. Now in the last, I think, 3 months, there's been 2 more direct primary care practices that have started in the Madison area. So another thing that makes healthcare really expensive is that we have some misconceptions about what is actually truly high cost and what we can actually shop around for. So things like prescription medications, labs, radiology, we just kind of assume that these things are going to be very expensive because maybe we've had experiences where they have been. But the reality is, again, that in many cases, if we don't use our insurance and we pay cash for things, we can get these things for a discounted price. So in a lot of direct primary care practices, including ours, we dispense medications out of the office. So pretty much any generic med we can order, we can dispense directly to the patient, and we just dispense it for what our wholesale cost is. So blood pressure medicine that might be, let's say you have insurance and you have a copay of $20 for that particular tier of med. Maybe it's $2 in our clinic. So again, you'd be better off paying cash for something rather than using your insurance for that. And this just gives you some examples of some common medications, and the orange prices are the retail prices and the blue prices are the direct primary care prices. So let's say, a person needs a MRI or an X-ray or a CAT scan. Again, historically, especially in our area, people are sent to the hospital to get these things done. The reason for this is because they can bill you a higher rate when you go to the hospital for these things. Unfortunately, around here versus Milwaukee area or Chicago area, we don't have a lot of freestanding radiology facilities. So again, this has to do with competition and lowering prices and transparency and a lot of different reasons. But when you get something done in a hospital, it's going to cost a lot more. So if you can get it done as an outpatient, that's always preferred. So again, in this direct primary care system, we try to help patients navigate to where they can get, cash prices for things like radiology. This shows you an example of an MRI if done in a hospital versus if done in an outpatient facility. And again, we don't own the MRI or anything. We're just helping, refer patients to certain places. That's actually, you can get an MRI for as low as $300 in certain areas. An X-ray, we do X-rays in our office. And that kind of shows you the cost savings of those things. So I wanted to run through a few examples of patients. These are kind of real life examples. So you have patient Joe, who's a middle-aged guy. He's got one chronic medical issue, so this might be a pretty common scenario. So let's say Joe has insurance. He might have a $5,000 deductible policy, and let's say he has a direct primary care membership. And kind of compare what that would look like if he utilizes his insurance versus utilizes the direct primary care. So after the Affordable Care Act was passed, it allows you one preventive care visit a year. You cannot mention anything else during that visit, or else you would be charged a separate charge for a different visit. But you also can have preventive labs done, which are included. Your colonoscopy, your mammogram, those things are included. But anything beyond that, for most patients, unless they have a zero deductible insurance, they're going to pay out of pocket for. So in his case, he has the $720 is what 1 year of direct primary care will cost him. He gets his wellness exam included in his insurance. If he does his preventive labs, his annual labs, those might be included with his insurance. If they're checking up on the blood pressure, it might not be. So it shows you the cost savings for labs, for visits, because his visits in the direct primary care system would be included. If he does have one sick visit, let's say once a year he gets sick with some kind of bad cold, flu type thing, showing you the visit is included. If we do an X-ray, that would be at a discounted price versus if he goes through his insurance. And then kind of at the end, in his one blood pressure medicine that he takes, he gets through the direct primary care. So at the end, it kind of shows you the cost difference. So again, this is someone who has insurance to cover for the catastrophic things, but he has not, in this case, met his deductible. So by having a direct primary care membership, he has saved over $1,000. And again, we never recommend to patients that they don't have catastrophic coverage. You always, there are very unexpected events that can happen, things like cancer, things like major surgeries, autoimmune illnesses, and things that will be very expensive to treat. So we want people to have coverage for those things. But again, I think there's different strategies that you can use. So this example is Bob, a 58-year-old. He has diabetes, maybe a few more chronic illnesses than the prior patient, and a little bit older gentleman. So in his case, he did have a couple of acute things come up, during the year. So again, his direct primary care membership in his case is slightly more because his age is a little bit higher. It shows you the preventive labs, again, if his insurance is including those once a year, but his regular labs to check on his diabetes, those will not be included. So it shows you the difference in price with the lab work. If he's getting his prescriptions filled with the direct primary care, he's going to save a lot of money. Again, all the visits, whether they're acute visits, chronic visits, preventive care type visits, those are all included in this direct primary care model. So it shows you he had a visit for the pneumonia, and then he had this chest pain, racing heart thing that happened. So at the end, after you add up all of the stuff for his chronic disease management, his acute visits, the difference in price is, $5,500 almost. So again, in his case, if he had a $5,000 deductible, he would have met that. If he had a $10,000 deductible, he would be still paying out of pocket for that. Last example, again, these are kind of real life examples, is Johnny, who is playing football and breaks his thumb. And part of the idea behind this direct care model too is that it's a little bit old fashioned in the way that there used to be like the family doctor that mom could call on the weekend if Jimmy had a cold, or that's kind of obviously I think fallen by the wayside in a large part. Maybe there's exceptions to that, but in this model, part of it is that we have a much smaller panel of patients that we take care of. So a traditional family medicine doctor might have 2,500 patients in their panel. Obviously, some of those people they're not seeing very often. In our panels, we might have 500 patients in our panel. So what that does mean is that, I don't get a ton of phone calls after hours, but if somebody does need something urgently, you know, they can call and talk to me at night or on the weekend. And there are circumstances where I've come in on the weekend to see a patient rather than having to send them to an ER or an urgent care. So in this case, you know, again, rather than sending him to an ER, we can bring him into the office. We can do an X-ray in the office. We can splint him. We also can cast him if needed. And part of our program through the direct primary care is that we can do telemedicine consultations with pretty much any specialist. So, you know, I can get that X-ray, send it to an orthopedist, get their second opinion to say, no, I don't think he needs surgery. Just keep him in the cast for 4 weeks, repeat his X-ray. So again, if you look at the cost difference in this, it's almost kind of mind-boggling how much difference the cost could be. So sometimes I hear from potential patients, you know, a lot of times people will say, well, I'm pretty healthy, so I don't really need primary care. I don't need, you know, for example, a DPC membership. But really, unfortunately, all it takes is one accident or injury where it brings you into an ER, and that could be thousands of dollars. So, I mean, of course, this $800 would pay for multiple years of membership for this little boy. So we kind of talked about the primary care part of this, but the catastrophic part. So, you know, what do you do for the situations where you do need to be hospitalized? You do need to go to an ER, you need major surgery, you know, you need to have some sort of coverage for that. So obviously businesses that are larger, you know, 50 plus employees, you know, they can be self-funded and do a direct primary care with that, which works really well. If you are a business that is fully insured, you know, what we tend to do, and I'm going to show you some examples, is do a high deductible health plan, which is paired with the direct primary care. You can also have a high deductible health plan, which is paired with an HSA, which can work also to use the HSA funds for the direct primary care. There are also these things called medical cost sharing. Next slide is. I'm going to get into those a little bit further, but I did give you a handout that shows you a comparison of some of those. So the rules around HSAs and HRAs are constantly changing. And when Trump was president, he had tried to expand what people could use these for, which was a good thing. And they did change the laws a couple years ago to allow people to use HSAs for things like direct primary care. And again, you can already, in most cases, use them for things like medications and other things, but depending on your HSA, sometimes they can be very restrictive. HRAs, again, they changed the rules a couple years ago that would allow HRAs to be used for, so the employer contributed HRAs to be used for DPC or these medical cost sharing things that we will talk more about. So medical cost sharing is an alternative to insurance. It is not insurance. It had some sort of a loophole through the Affordable Care Act where they did not make them comply with the same requirements that insurance had to comply with. They have been around for maybe 20 years. They started off as faith-based. So they started off as like a church or something, you know, putting together collectively money to say, okay, we're going to pay for Mrs. Jones' hip replacement. And kind of from there, they have led to these larger, you know, nationwide groups of people that are basically pooling money in case somebody needs something catastrophically. In general, the cost of these things are typically much less than traditional insurance. There are some cautionary things about them. So because they don't have to comply with the insurance laws, they do have pre-existing condition, you know, carve outs. So if somebody has a pre-existing condition, they aren't required to pay for that for the first 3 years. And so you do have to, they don't have to have the same preventive care coverage. So basically this is kind of truly like what a catastrophic policy used to be, where they don't cover anything until you meet your deductible. Typically, and they use different terminology. So a deductible, they call like an initial unshared amount. But once you meet that, and usually they are traditionally a lot lower than insurance. So it's not a $5,000, $10,000, $15,000, it might be $500. But this chart that I have here, and I also can email this out, is a good comparison that shows you the more popular health shares, what they cover, what their costs are. Sedera gives discounts for businesses, and they give you a further discount if you are enrolled in a direct primary care membership, because they recognize that those people are going to utilize the system less if they have a direct primary care membership. So I work with a really great insurance agent, and she's done a few of these slides and kind of put together, what common things that might happen, or even like a worst case scenario, because people are understandably very worried if they don't have traditional Cadillac insurance, what happens if something bad happens. And I think, unfortunately, sometimes that fear keeps us stuck in a system where we're paying a lot of money for health insurance and not really utilizing it very much. They say the average person will meet their deductible like every 8 years. So again, we'll talk more about that. So this is maybe a common situation where you'd have some lab work done, you'd have 4 office visits in a year and a couple generic medications. And this is kind of more to show you at the bottom of what the out-of-pocket savings would be if, in this case, in the second 2 cases, they have a direct primary care membership. In the case where they have a low deductible policy, they do not. So because they did not have a direct primary care, they paid more for their labs, they paid more for their prescriptions, they paid their co-pays. But again, it's showing you if they had paired that insurance with the DPC, kind of what the savings could look like. So what if you have a very unfortunate situation where you have cancer or you need major surgery? Then, obviously you're going to meet all your deductibles. So this person met all their deductibles. Again, the problem with insurance is that, nobody can ever read all the fine print, and you have a co-insurance after you meet the deductible. Maybe some of your prescriptions aren't fully covered. You usually have a maximum out of pocket that you have to reach. But so in this case, kind of ironically, they paid more with the lower deductible than they paid with the $2,500. They paid more with the zero deductible than they did with the $2,500. And then I don't want to bore you too much with the details. So this is another scenario where insurance is very important. If you are taking a very expensive medication that does not come in a generic, for example, insulin, injectable immunologic meds for rheumatoid arthritis, lupus, those sort of things, expensive respiratory medications. Those things you have to be very careful about, because if your insurance covers them and what tier they're on, it could be thousands of dollars a month. So this is a person that had an expensive medication that they're on. And again, the difference between the zero deductible and the $2,500 deductible, with a DPC membership, because again, some of their visits and things are covered through the DPC. And then in their case, it wouldn't make sense to have the high deductible because they're going to meet that deductible because of their meds. So I know that was a lot of information that I just showed in those last 3 slides, but kind of the take home that I'm trying to convey is that, sometimes we look at insurance and we think that the lower the deductible, the better, or we just, kind of gives us the peace of mind of like, I don't want to have to worry about this, so I'm going to get the zero deductible because then no matter what happens, it's covered. But when you really run the numbers, you realize that you're paying so much more a month. So this is just a hypothetical situation of an employee, what they're paying in their premiums. And like this would be for a year. And so what they would pay in premiums over a year, and let's say their employer is paying 50% of that. So this is their portion. And we see that, let's say for the employee, and the difference between a zero deductible policy and a high deductible policy is, $2,000, right? So again, if you're meeting your deductible once every 8 years, which of course you can't predict those things, but if you find a place where, like, if financially a person's comfortable with $2,500 versus $6,600, it's better to get the higher deductible of what you financially are comfortable with your budget, because in the long run, you're going to save money. And this just shows you kind of the price difference. Again, the difference between a family being covered and on the high deductible and the low deductible is you could save that, whatever that is, $3,500 a year, and obviously do a lot with that money. Sorry. So overall, the idea behind kind of pairing direct primary care with a health insurance or with one of these health shares is that, as an employer, again, depending on the size of your company, if you're over 50 employees, they will base your insurance rates on utilization, or they will at least look at that. So again, we have businesses that have like 80 to 100 employees, and they we'll get a printout of, how many MRIs were ordered and the cost of the care and when the patient went into the hospital. And if we can lower utilization, that's going to actually, be beneficial when their premiums come out the following year. So again, you don't have to worry about a deductible being met with your primary care portion, because that's already, immediately you can utilize the direct primary care. What we see with health insurance, I don't remember if this is just an individual or employer, is basically, I think it's employer, it's going up somewhere between 8 to 10% every year. With COVID, it kind of threw a little bit of a monkey wrench in it, because I think in some people's cases it went down. I mean, utilization obviously went way down with COVID. But now what we're seeing, I think, is people are utilizing more because they've been waiting to get all this testing done until now. So, my perspective on it is that we have to figure out a better way to do this, both financially, so people can actually afford to get healthcare, and just the quality of the care that people receive. I gave you a brochure, and a lot of this information is also on the website. But this kind of just gives you an example of, so again, our direct primary care practice, one of now 3 in the Madison area. But part of this model is transparency of pricing. So all of our prices are on the website, brochure. If a patient ever has anything ordered in our office, whether it's an x-ray, a medication, any sort of testing, they know the cost of everything before they leave. So it's really nice. And this kind of also talks about what the membership includes. I gave you this handout, which is what I showed up there, which kind of gives you a comparison of all the health sharing things. And, you can visit their individual websites to learn more about them. I personally have one of these. I just kind of hate health insurance in general, so I try to stay away from it. But this is also examples of, I use some up in the presentation, but these are examples of our pricing as far as common medications and procedures that we do in the office. Sometimes we charge like a very nominal supply charge. Laboratory pricing, and then radiology that we do. Some of this we do in the office, some of this we refer out for. I don't know if there were any questions like in the chat part, or did anybody here have any questions?
I don't know if you covered the approach you take with small businesses with 5 or more members.
Yeah, they get a 10% discount. And if we have a business of more than 30, they get a 15% discount. Yeah.
Okay.
Yeah, and so I guess what I would say, our experience working with businesses thus far, we have individuals and families and businesses. When we started out, it's kind of a challenge, but finally found an insurance broker that was willing to kind of like embrace this. So now we have one self-funded company, and we have probably 4 businesses in the range of like 50 to 100, and then we have a lot of 5 to 25 employee businesses. But yeah, our practice has grown. We have now 2 locations. We have 2 doctors, and we're adding, in the process right now of interviewing for a 3rd, probably a 4th next year. So it is something that's growing. I know. So some of the challenges or the things that I hear is, we aren't UW or say SSM or GHC. We can't compete with a clinic on every corner. But I guess I always tell people we aren't really trying to compete with that, because what we're offering is something that's, very different in terms of the experience that people get, more personalized, smaller. Some people maybe don't necessarily want the gigantic system. So this is a very small system. But yeah, so that's one of the challenges, some people, but right now we have people that drive from Wisconsin Dells to come to us. We have Janesville, people driving from Janesville, Waterloo, pretty much like an hour in any direction. So, but I think as this grows, we'll see more of these type of clinics, coming up. Yeah.
So do you guys do like primary care? So like, would you be like a primary care provider for not the non-serious, the things that's not serious, right?
So family medicine, we can do any kind of chronic disease management, preventive care, so like well checks for well women, well children. We can do chronic disease management like high blood pressure, diabetes, thyroid, but yeah, we can take care of any of that. We don't do major surgeries. We do minor surgeries, like I think it was on that one slide. But yeah, what we find too is that in this system, because we can take more time with patients, we tend to, there tends to be less referrals because we're not having to send them out for everything. Even just less referrals for x-rays and blood tests and things, because when you actually have the time to take a pretty thorough history, you can figure out some more things.
How does it work for specialty referrals? Do you work with UW? Do you work? Can you explain that a little bit more?
Yeah, so we don't have there's no issues with us referring to UW. We don't obviously have any kind of formal agreement with them because I think if anything, they probably would wish that we didn't exist, but we can, so they take any kind of referrals from outside private docs, like we don't have to be in network or out of network, even if they have an HMO. So what we tend to do is if it's something that we just need like an answer to a question, we need guidance, we need a second opinion, we'll use this telemedicine specialty service that we pay for, patient pays nothing for it. So like that example I used about the kid that broke his thumb, we can send them x-ray, they can review x-rays, labs, EKGs, they come back and this is a board certified, specialist that's reviewing it, and they come back and they say, no, he doesn't, this is what you should do, this is what medication I think that would be good for them, do this additional blood test, and then that's completely free to the patient. If a patient needs, let's say, a surgery or a procedure done that needs to be done by a specialist, it will depend on what their insurance is. And again, so if they don't have insurance versus if they have like a $10,000 deductible, I'll give you an example. We had a guy that needed a thyroid cyst biopsy, and he actually had one of these health shares, and I think he had like a $2,000 deductible or something. So we called one of the local hospitals, or I called one of the local hospitals. It was going to be $6,000 to do the procedure and the pathology for a thyroid, which they have to do in the hospital, of course. So we ended up sending him to Milwaukee to an interventional radiologist who took out the sample. It was $240 for that procedure. And then he brought the pathology back to us. We sent it to the pathology group. We used that was $40. So we had the whole thing for less than $300 for something that they were going to charge him $6,000 for. And that kind of stuff like happens all the time.
So why, I think I'm halfway educated on health insurance, a little bit. Why is this the first time I'm hearing about?
I think because we are like, it's like David versus Goliath. We're like a handful of doctors. If there's 700 DPC doctors in the entire country versus that, hundreds of thousands of doctors that are working for big systems. There's no motivation from hospitals or insurance companies to lower cost, right? They're profiting off of the system being this way. So it really has to be a grassroots movement that's driven by patients and doctors that are just sick of the system and aren't, so it is kind of this whole free market medical movement. It's happening in some parts of the country. It's been going on for, like in Texas, Florida, Colorado, there's hundreds of DPC practices like this. The Midwest is a little bit slower, in our area specifically, we are heavily HMO saturated, and historically private insurance. So you don't see like the BUCAs, they call it, like the Blue Cross Blue Shield United, right. Aetna. You don't see those here, right? All we see here is Quartz and Dean, right. GHC, because they have saturated the market and they can offer very competitive rates to employers. They're still not like that good of rates, but yeah, so I guess this market is a little bit harder to crack into because we do have those HMOs that are kind of, causing there to not be a lot of competition. But yeah, I don't know why. Yeah, I think most people haven't heard of this, but.
So you would recommend some sort of health insurance brokerage or individual to assist on kind of putting together a plan? Is that what you're saying?
Depends on what your situation is. Like if you have a business and if that's what you're looking at, then I would say yes, definitely go through like a broker. If your situation is, you can purchase it off of the healthcare marketplace and just look for a high deductible policy. And again, depending on what your income is, sometimes you'll be given a subsidy through the marketplace. Biden has increased a lot of those subsidies. You can go directly to the insurer. So you can go to Dean or Quartz on their website and price out a policy too. But yeah, if you have a more complicated situation, an insurance broker will probably help you navigate that better.
Explain what you mean by a broker.
Or even like a employer health benefits person. So the problem, to be very frank, some health insurance brokers are paid based on the policies they sell, right? So if they're paid based on a commission, not all of them, to sell you an expensive policy, they get a percentage of that. So I mean, that's part of the challenge of this is like, they wouldn't necessarily have a motivation to turn you to DPC, right? Because they would have a more of a motivation to sell you a Cadillac Quartz policy. But there are brokers out there that aren't paid that way. And I mean, I'm happy to provide you names of people.
We have a question in the chat
Yeah.
that people have been waiting a little bit here for. So they said, I'm a freelancer with no employees. Would I be able to use this? And could I include my husband in the coverage?
Yes. Anybody can use this. Yeah, so we have individuals, families, self-employed people, businesses. Yeah, they can do it as an individual and a family. We have a lot of self-employed people.
And we have another one. Kind of Julie says, I'm a broker agent. I've been involved in this concept for several years. Love to chat and get specific information on the doctor's practice, hear more about specifics on location, et cetera. It's great.
This is, I mean, just so you know, too, to kind of put things into perspective, this is something that, for example, SSM Health is doing a pilot, direct primary care pilot down in St. Louis, where they're based, where their employees and small businesses down there can enroll in a direct primary care through SSM. And they're contracting out with like a third party. There are these corporate DPCs, which are very large, you know, they contract with companies of, you know, thousands of employees. But so I think people are recognizing the value in this. And again, the reason that we can keep the prices low like this is because for a primary care doctor to eliminate insurance and the staffing and overhead, you know, with that, eliminate somewhere between 30 and 50% of our overhead costs. So instead of having, you know, a coder and a biller and an extra front desk person, instead of employing those additional people, we just keep the cost lower for the patients. So it is a very different kind of model of care, but I think, you know, again, it allows us to spend more time with people and it seems to work out well. Anybody else?
Yeah, so if I were to come in for a wellness check or my kids, is there an expected amount of time that you would spend, or how do you then make your appointments then, I guess, if you?
Yeah. So all of our appointments tend to be an hour. We do occasionally have urgent cares that are 30 minutes, but yeah, we book an hour for each patient. So my typical day as a family medicine doc, I mean, I might see 5 to 7 patients in a day, which is like unheard of. I mean, you know, in the system, they're seeing 25 patients in a day. But again, yeah, so I can spend a lot longer with them. But yeah, patients can book online through our website.
So it sounds like as somebody that would be a client of yours, you'd have to be probably two things: confident in you personally as a doctor, that you could meet their needs, and confident that like they can navigate the system. Does that seem like the two things that, and a drive to go outside the system, obviously,
Sure.
is the hit.
Sure. I mean, I think confidence in your doctor is probably good in any scenario. I mean, it is different than like, again, like a UW system where maybe you walk into a clinic and there's 20 different doctors to choose from. Yeah, in our system, there'd be 2 of us, which that's going to change, you know, get bigger. But yeah, I think you have to like your doctor and trust your doctor. And then the second part of your question, tell me again, what was the second part?
No, I was just saying, like, we're trying to think of the motivation of a client to go with a DPC.
So the motivation would be lower your healthcare costs, because health insurance for a lot of households or employers is a massive cost. And then just you want something that you're not getting in the traditional. This doesn't exist in the fee-for-service insurance-based system. You're not going to have a doctor spend an hour with you. You're not going to have a doctor that you can call on a Friday night when you have an issue that's going to talk to you. I mean, you might have an answering service or a doctor on call. You know, so it's a completely different level of care. So this was actually a spinoff of concierge medicine, you know, back in the 80s or 90s, which still exists. There's a doctor in San Francisco right now. I think his practice is called Private Practice Medicine. He charges $70,000 a year just to have him as your doctor, and he still bills your insurance, but he has probably like 50 patients. So, I mean, he can do everything for you. I mean, you wake up with a sore throat, you call him, he answers the phone. So part of this, again, we're not charging $70,000 a year, charging $70 a month, but the idea that you have a doctor that's going to be accessible to you, right? Because I don't know what you all's experience is. A lot of people call the doctor and they need an appointment, and you might be told, well, they don't have an appointment for 2 weeks. Well, go to the urgent care, or, you know, so the accessibility the quality of the care you get. Because again, I would argue that if a doctor's spending an hour with you versus 15 minutes, I mean, that they got to be finding things, you know, helping with things that they couldn't in a 15-minute visit. Yeah.
So you mentioned before that this is kind of like a grassroots, and I would agree, this is not something that you're going to hear out in the medical realm, especially not in the Dane County area. How would you suggest, or how would you come alongside, like even the people in this room and online learning about this for the first time, to actually help get the word out, just in the patients that I see and the copious number of people that I interact with? That is the biggest drawback from consistent holistic care, is the insurance side, or the headache and the stress that actually causes more health issues because they have to deal with insurance and not really understanding the minutia of even how to navigate the system when they do belong to something like GHC or Dean or whatever the case may be. So what is something, and I can only speak for myself, what is something that I can do to help get the word out with the different people that I work with and the different clients that I have, to even allow them to know that there is another option? So what are some of your suggestions, or how do you guys work
Yeah,
that?
so there, I mean, well, first of all, we're always happy to talk to people. I mean, so like even if you give them our email or phone number, we're happy to talk through like what their situation is and, you know, what services we offer, that sort of thing. But there are some good websites out there. So DPC Frontier specifically, they have a DPC mapper on there where you can pull up a map of the whole country, and it'll show you all the direct primary care practices in our area, other areas. You can click on them and it'll show you their website, what they charge, you know, pretty much everything. It will also tell you about direct primary care in terms of like legal, like legislation. We tried to pass some legislation 2 years ago, which unfortunately did not pass. But basically in many places, it's kind of unregulated. Like, you know, as physicians, we're allowed to open up a medical practice like we've been doing for, you know, thousands of years. But because we are operating outside of the insurance market, we are not under the oversight of the Office of the Insurance Commissioner. So, you know, again, that's what we're trying to prevent from happening, because then again, they would start, you know, doing all these regulatory barriers and making things more expensive. But so, yeah, so DPC Frontier is a good one. There's a Free Market Medical Association that is a good website that also there's, I think it's called like the Blue Book or something, but you can go on there and actually get prices for things. But yeah, I think that there's another one called DPC News, but yeah, I think that the DPC Frontier is a really good one to go to. But yeah, that you can, you know, visit our website. There's a lot of information on there too. Yeah, I think that it's definitely something that's not going to be promoted by the big systems, but like within our, like the American Academy of Family Medicine, they're promoting direct primary care now. We have a conference once a year. I mean, there's actually 2 big conferences that happen. So, I mean, it is something that's like in established medicine, and like physicians know about it, but I don't think people that aren't physicians really know that much about it.
And that's the pocket of people that I really care most about, are the end users, the ones
Yes.
that are suffering with copious medical bills and not really getting the care that they need, or even going into a big ticket physician's office and having care practically withheld because the insurance won't cover it, type thing. So that's the population of people that I'm hoping to get a hold of, because this is really quite amazing, and I think it would be very beneficial.
Thank you. Yeah, and I mean, I think you bring up a great point, because we do, in a lot of cases, you know, we gear the medical treatment towards what the person can afford. Like, oh, well, we can't do that X-ray, we can't do that blood work because you can't afford the $400 for the blood work. It's like, well, if the blood work's $5, we can do it. We can get the X-ray. You know, it's sadly, I think that's what it's become. And there are people, you know, again, we have this misconception that everything has to be super expensive. I mean, I have patients that walk in and they're like, well, I've needed an MRI on my back for 10 years, but I can't afford $4,000. I go, well, what if it's $500? Well, yeah, I can afford that, you know? So yeah, I think it's definitely kind of eye-opening.
Present to businesses?
Yep.
Okay.
Yep. I can do it by myself or with the broker that I work with. Yeah.
Could you give us kind of an overlay? You touched on it a little bit, but maybe a little bit further here as far as your business is concerned. So you started in Middleton. You've now just opened the location on Fair Oaks. You're talking about adding some more doctors. Where do you see this going as far as your business?
That's a loaded question. No, I'm just kidding. Yeah, so I started in January of 2019 by myself. So I had no staff. I drew blood. I had to go back and learn how to draw blood, and I checked people in, answered the phone, scheduled people. And that's how most of these practices start. And then and I also was kind of in a unique situation because I was basically employed as a hospitalist and doing ER work prior to that. So I was not converting an existing primary care practice where I could bring patients over with me. So I started with 0 patients. But so now we've grown to where October of last year, we opened up an East Madison clinic. I added a second physician, Adam Balin, who's really great, worked with SSM for 25 years. And so now we are in the process of adding a third. I'm hoping to add a fourth next year. I'm hoping to add an office in Fitchburg within the next year. You know, it's a little bit hard to know because I mean, you know, we want to grow, you know, but you know, don't want to grow too fast. I mean, and you know, it's a little unpredictable as far as like what the healthcare climate's going to be like in 5 years or 10 years or, you know, but yes, we definitely are growing and we are looking to add doctors and make, you know, have more locations so it's more convenient to people. I mean, it's amazing just even adding the second location. Because we used to get phone calls from people saying like, I don't want to drive to Middleton. I'm in East Madison. And I'm like, okay. So we put this East Madison. I mean, and it has been really good because I mean, people, I mean, it is much more convenient to drive 10 minutes to see your doctor than 25 minutes. So, you know, it's
The whole other side of the city.
coming from Chicago, we were like, we drove 45 minutes to go to the grocery store and I was like, can't drive 5 minutes. Yeah, but it's been really good. Yeah, and I have a full-time medical assistant. But yeah, as our practice grows, then we'll continue to add people. But yeah, oh, by the way, we are doing an open house next Wednesday. I was going to say, if anybody wants to come in at the East Clinic, and I think it's on our Facebook, if you want to go to that. But if anybody wants to just see what the clinic looks like, because it does look like a regular medical clinic. You know, we're not operating out of the back of a van or anything like that.
When would this be?
It's next Wednesday from 12 to 6. So it's a pretty long time span. Just, you know, we're just having people come in, refreshments. You can see the office. You can meet Dr. Balin.
Must be the 7th.
That's gotta be it.
Right.
Sounds right.
So you do need to essentially piece together a health plan, but you can help with that.
Exactly. And I think that is part of the challenge, because I mean, I think sometimes people, when they buy their insurance or when they check the box for the employer insurance, it's like, okay, this is what the plan I'm picking. And this you do have to like, it's a little bit more work up front. Even for employers, it's a little bit more work up front, right? Because they're having to like piecemeal something together. And I mean, I've talked to health benefits brokers that have been like, well, you know, employers don't want to have to do this. This is too like complicated, or it's really not. And again, if you find somebody that really is invested in making healthcare more affordable, then, you know, they're willing to put in a little bit more time in the beginning. But yeah, we will definitely help people figure that out, like what the catastrophic piece is.
Any other questions online?
Well, thank you very much, Colin, for having me.
Yeah, thank you for joining us. How can people reach you if they have further questions?
Yes, if you go to our website, www.advocatedpc.com, there's a contact us page on there. So you can send us a message through that, and our telephone number is on the website too. So you can either call us or send us a message, and we're happy to answer any questions. If you have a business that you want us to come and talk to, we're happy to do that.
And the material that you handed out here, obviously those that are online don't have that. Is this on your website, or how can we get that to?
Yeah, I can, the brochure, I bet that pretty much all the information in the brochure is on the website, but this I can send to you. I can send these to you.
Okay, so if someone would like copies of that, just reach out to myself and I can email that over to you.
Great.
All right.
Thank you.
All right, great. Thanks for joining us today. Appreciate it.
Thank you.
We'll end that with Zoom